Hi, I'm Georgina Mankey and I'm filming my airway management video in September 2013. The purpose of the video is to demonstrate airway management skills in accordance with the clinical work instructions. I'm going to demonstrate placing the patient in the lateral position, the triple airway manoeuvre and how it differs from sniffing position, the safe insertion of a nasopharyngeal airway and oropharyngeal airway, laryngoscopy, and positive pressure ventilations using a bag valve mask. Laryngoscopy is used to visualise the airway and also to assist in the visualisation and removal of foreign bodies. My patient needs to be in a supine position with a pad below the head to help maintain a sniffing position. My oxygen and suction is on the right, the laryngoscope is on the left, and I am behind the patient's head. First of all, I need to check that the blade and the bulb of the laryngoscope is tight and bright. I'm going to support the patient's head, gently rotating backwards, and open the mouth. Holding the laryngoscope in my left hand with my thumb along the handle, I'm going to insert the blade to the far right of the mouth. I'm going to look left and right for obstructions and use suction if required. I need to further insert while sweeping the tongue to the extreme left until I'm in the vallecular groove. Applying pressure with my thumb and hand, lifting upwards and vertically, I need to visualise the vocal cords. If the vocal cords are not visualised, I need to remove the blade and start again. When the vocal cords are visualised, I need to make sure that there is a clear airway and that the vocal cords are in clear view. A common mistake made is levering angularly the handle and the blade of the laryngoscope, which can damage teeth and cause mouth trauma. I will now demonstrate the insertion of an oropharyngeal airway, or OPA. It's indicated in patients who are unconscious to maintain forward displacement of the tongue and also as a bite block to support an endotracheal tube. It is contraindicated in patients with a present gag reflex or with trismus. Before insertion, I need to prepare the patient by performing the triple airway manoeuvre. Tilt, lift and thrust. Then I need to select the correct size OPA. This is done by measuring from the corner of the mouth to the angle of the mandible. A common problem is selecting an OPA that is too big, which can cause damage to the mouth or occlude the airway. Then I need to lubricate the OPA with water or the patient's own saliva. Holding the flange with a natural curvature upside down, I will insert it halfway into the patient's mouth. Once there, I will gently rotate it 180 degrees whilst continuing to insert until it reaches the patient's lips. I need to make sure that the bottom lip is not pinched between the teeth and the flange. If there is a gag reflex, I will remove the OPA straight away. Once the OPA is inserted, I'm going to look, listen and feel the air movement whilst also maintaining the triple airway manoeuvre. Positive pressure ventilations are used to assist a patient with breathing. The patient can be in a supine, lateral or seated position. First of all, I need to check that the airway is clear and measure and insert an OPA. Inserting at a rate of approximately 10 mils per kilogram, or around about a third of the bag, I'm going to provide 12 ventilations per minute. I'm going to roll the mask onto the patient's face, and I may need to bunch the cheeks to do this to get a good seal. The tip is on the nose and the base is on the chin. My thumb is going to be on the tip and my fingers are on the chin and underneath the mandible to maintain a good seal and also to support the chin. 12 ventilations a minute. Whilst doing this, I need to observe for rise and fall of the chest. A common mistake made is over-squeezing the bag, which can overinflate the lungs and push air down into the stomach. Lateral position facilitates the free drainage of fluid and also stops the tongue from occluding the oropharynx. I need to check the pockets for any sharp objects. The forearm is extended from the shoulder, the near arm is placed across the chest, and the near leg is bent at the knee. I then need to gently roll the patient using my hands on the hip and shoulder. The top leg is bent at a right angle towards the face, and the top arm is pulled away from the face. I then need to straighten the neck and roll the head inwards. A common mistake made is not rolling the head inwards, which can stop the drainage of fluid and cause choking. The triple airway manoeuvre involves a head tilt, chin lift and jaw thrust, and is aimed at straightening the airway and pulling the tongue away from the oropharynx. Adults need a 2 to 5 cm pad below the head. Children need to remain supine, and infants need a 2 cm pad below the shoulders. First of all, I'm going to inspect the mouth and suction if required. I'm going to use my right hand to place it on the patient's forehead, with my thumb pointing towards the nose. I'm going to use the thumb and index finger of my left hand and place it on the point of the chin. Gently applying pressure to the forehead, I'm going to extend the head backwards. A common problem made is overextending the head, which can cause cervical damage. I'm going to apply pressure to the chin, lifting it upwards, allowing the mouth to open slightly. Then I'm going to place my thumbs on the patient's zygomas, my index fingers on the body of the jaw, and the rest of my fingers under the angle of the mandible. Applying pressure under the angles of the mandible, I'm going to protract at right angles to in line with the pharynx. This differs from the sniffing position, as the sniffing position only maintains the nose in line with the sternum with a straight airway, and the triple airway manoeuvre also involves a chin lift and a jaw thrust. The nasopharyngeal airway is an airway adjunct used as an alternative to the OPA. It is indicated in unconscious patients with trismus, and contraindicated in patients with middle third facial fractures, significant nasal trauma, and traumatic brain injury, or a significant neurological event where, despite trismus, tidal volume is adequate and there is a patent airway. Precautions should also be taken with significant basal skull fractures and when CSF is leaking from the nares or ears. First of all, I need to attempt a manual clearance and also attempt to insert an OPA. I then need to perform the triple airway manoeuvre. The correct size nasopharyngeal airway is selected by measuring from the tip of the nose to the earlobe. I then need to lubricate the NPA with some KY jelly. I'm going to inspect the nostrils for obstruction and select the nostril that is larger. The diameter of the NPA should be slightly smaller than the diameter of the nostril. Gently pulling the tip of the patient's nose back towards the face, I'm going to insert the NPA, rotating 45 degrees backwards and forwards. The NPA needs to go along the floor of the nose at a right angle. I insert to the measured length. If there is resistance felt, I need to stop and not force, as a commonly made mistake is forcing it, which can introduce the NPA into the patient's brain. Once inserted, I need to check for a gag reflex, in which case it needs to be removed, as that can cause increased intracranial pressure. And then I need to look, listen and feel for airway movement.